Cool. You guys are too kind. Let me call that. Nonetheless, I appreciate it. Very excited. Thank you so much for showing up. I have to send a sincere hand of gratitude. I really just thought it was going to be myself and Dr. Hyacinth here, just discussing the whole pedo-endo sort of issue. My name is Marcus Johnson. I am an endodontist in private practice here in Manhattan off of 30th, 40th Street in between Park and Madison. Just opened up about a year ago. And then I also associate with my mentor, Dr. Al Granger, in Long Island. I really pride myself on practicing evidence-based endodontics. So I'm going to go through some slides with you, talk about a few issues that are very important to me, but hopefully you'll be able to take some key pearls of information away from it and learn and apply it to your own practice. But any and everything that I discuss, there is some literature to back up why I use it, why we're discussing this, because I think the literature is so valuable. We are dentists, we are scientists, and it's important for us to really know the basis of why we treat, couple that with empirical data, and then deliver the best treatment for our patients. Okay. So yes, welcome to the lecture, Regenerative Endodontic Procedures, a new protocol in the management of open or immature apices. Now it sounds a little bit probably more convoluted than it actually is. It sounds extremely scientific, but once we get into it, you'll see that it's pretty basic. And really it's just a nice way that I'm able to frame a few techniques that have been introduced into the endodontic literature that you can go ahead and take and adapt to your own practice in residency or what have you, and then apply that on your patients and hopefully have some successful cases. Of course, I would be remiss if I were not to thank Dr. Carrie Cunningham for just allowing us to use this space right here. So hands up. Thank you so much. And a lot of you are just, maybe finishing up or looking to finish up within the next year. Please, enjoy some conversation with him. This is a beautiful space. It's very nice, it's quaint, and it's a trendy neighborhood. It's up and coming, so we're looking for new people to come down to this region and start practicing. A lot of, I guess, superstars in this area. I think it's been rumored a famous rapper lives around here. His beautiful wife. I'm not a big fan of Jay-Z, but he's not too bad, guys. He does have Beyonce, so we'll give him a little bit of credit. But enough about my celebrity crush. I don't believe time is too much of an ally, so I'll go ahead and goals and overviews. We really can't discuss this topic without understanding the basis of why we do what we do. So we're going to get into a little bit of microbiology, look at some literature on medicaments and irrigants. In addition, review some traditional treatment methods used to manage open apices, probably a lot of them that you may be familiar with. And then, of course, we'll get to sort of the hallmark of this presentation and highlight that new treatment protocol for regenerative endodontic procedures. Just to poll the crowd, can you guys tell me, mainly the pedodontists, what are you guys doing when you see these cases of, immature apex? Someone comes in, they have a tooth trauma. What are you guys doing when you see these cases? Are you familiar with the literature? Are you comfortable managing these type of issues? Just like what is your initial sort of response? And I forgot to mention, please, I don't want you to think that I'm lecturing to you guys. I want this to be an open discussion. Like I was kind of joking when I said I thought it was going to be me and Dr. Hyacinth. I really wanted this to be a general conversation. 2 years ago, I was in your shoes, just listening in on lectures, trying to learn as much as I can. I still learn when I'm up here talking, so ask me questions. Let's just engage in dialogue. So at the end of the day, we want to be the best clinicians as possible. No need to settle for mediocrity. Let's excel. So please feel free. Okay, so I'm assuming.
I'm familiar with the procedure, but I personally haven't treated a patient like that. I feel I'm dental traumatized after.
Yeah, with Andreasen, right? Andreasen, he's phenomenal. Anytime you need any sort of guideline how to treat someone who has a fracture, what have you, that's the source. But what I'm saying is, what are you guys doing if you see a case of an immature apex, like a child comes in, 9-year-old, open apex? What are you doing? What type of procedures are you normally doing?
You have to monitor it, but then ideally, in the residency we talked about, we're set up to do that with the triple antibiotic paste and revascularization followed by MTA.
Good.
Ideally, you want to follow up vitality and give it a shot, because a lot of times that initial trauma will not respond to thermal testing shortly after the trauma.
Okay, so I just want to get an idea. So it's nice to know that you guys are even familiar with what I'm going to be discussing. Okay. So regenerative endodontic procedures. Okay. What is the basic, I guess, goal of this new protocol? Essentially, we just want to regenerate functional pulpal tissue utilizing various treatment protocols. I wanted to stress treatment protocols because what we're saying is that the literature is still in its infant stages. So we're getting a lot of literature, a lot of sort of case studies from different practitioners, not really high-level evidence studies. And we're just kind of adding this to a database, and we're saying, here's kind of the guideline, and then apply where it's necessary. And then we're seeing some successful cases, some cases that are not that successful, but it's ever evolving. So that's why we always want to stress treatment protocols. Regenerative endodontic procedures is going to encompass pulp revascularization. This term kind of stems from the dental trauma literature. You mentioned Andreessen earlier. Okay, right. And so when we think about revascularization, we're thinking about maybe some sort of avulsion case. And what happens when you have an avulsion is the tooth is obviously knocked out the socket. We have to go ahead and reinsert it. But what you're relying on is that native tissue that's already present within the canal to sort of regain that blood supply, either through angiogenesis or some sort of anastomosis process. Okay, so that's just at the basic level for revascularization. There's been some confusion in the literature versus revasc and regeneration. It's a big difference because when we talk about revasc, like I said, we already understand there's tissue, vital tissue, or some sort of native tissue that's already present. The phenomenon of pulp regeneration is that we're dealing with a case that is necrotic. There's infection, inflammation, okay? And now we take that and we're able to sort of bring together a new life, a new tissue, so to speak, within the canal space. So you're dealing with a tooth that has undergone maybe some sort of liquefractive necrosis, and now, after initiating these sort of procedures, you now have a tooth that not only responds vital, increased apical wall dentin, apical thickness, and increased apical development. Okay. And the way that it occurs more or less is through tissue engineering, and then we couple that with regenerative medicine. Okay, so we're going to be discussing a little bit later stem cells, scaffolds, and growth factors, and how all of these sort of repopulate the canal space, and then we end up with a regenerative endodontic procedure case that is successful. Bonches and Trope, 2004, JOE, Journal of Endodontics. Is anyone familiar with this study? Okay. Classic literature. This is a classic study.
Knocking at the doorbell? No. Him.
Okay, this is classic literature, and the hallmark of this study is that Bonches and Trope, they're great endodontists. They're actually world renowned. They had been kind of following the Japanese literature, okay, and they had seen cases where they were noting that okay, we can maybe apply some sort of special medicament within the canal. The tooth that was previously necrosed now is actually showing some signs of vitality, this and that. So they said, well, why don't we see what we can do? Let's apply it here in the States and see what happens. Okay. So this was the case that presented. You have a 11-year-old child came to the clinic, and this is what you see. When you see this, what does everyone think? Probably you're saying, oh man, this is hopeless. Saca la muela, right? Take it in. But in actuality, they said, no, we see that this is a potential to bring something back to life, okay? So, diagnosis, necrotic pulp, chronic apical abscess. I'll get into diagnosis a little bit later, but it's important that you guys understand that in about 2004, the American Association of Endodontists, we kind of came together and collectively said we need a new sort of diagnosis format so that we can speak in a collective language and understand one another across the basis. So it's kind of standardized. So this is the new diagnosis. No more chronic, what was it before? I don't remember, to be honest. What is it? Just for the residents, we said use a different semantic system. But necrotic pulp, chronic apical abscess. Obviously, we can see that it is necrosed because this is a sinus tract that traces right to the apex. You have the gutta percha tracing right there. You can see just all the lesion. It extends all the way up to the cervical region down here in the apex. Most people would extract this too, okay? So what did they do? They went ahead and initiated some regenerative endodontic procedures, and now you can see in a 2-year follow-up, we have increased apical development, dental wall thickness, but the kicker is that now the tooth, which was once necrotic, no response to endo ice, now is vital. That's pretty amazing, right? So we're going to discuss how that occurs, but I just want you guys to have a picture to sort of associate what we're going to be getting into a little bit later. But of course, before we can get to that point, we have to understand what we're dealing with and what are the best ways to go ahead and eradicate that. So just to poll the crowd, what is the etiologic agent in any sort of endodontic infection? Don't be shy. It's not hard. Remember, I'm just a regular resident like you. We're just having a good conversation. Excuse me?
That's bacterial name?
Yeah, it's bacteria. Microbes, right? The etiologic. What is that?
I just said I said it, Martha.
Oh, okay. But I should probably note, this is my mother. Beautiful smile you see back there. That's my mother. Just a side note, whenever I treat patients, I always lead with, okay, you know, you're in great hands. Please don't worry. I'm very good at what I do. And I will treat you as if you were my own mother, who I love dearly. Okay. You have to put that in there because sometimes people don't love their mom. The funny thing is, she flew 3,000 miles from Denver, Colorado, my hometown, and I actually did a root canal on her today. So
and I'm alive and
well. There's a lot of truth to that now. So when I say it to my patients, there's a lot of truth because I actually just did a root canal and everything worked out well. So God's good.
Yes.
But yeah, it's bacteria. Okay. Again, classic endodontic literature. Takahashi, Stanley, and Fitzgerald in 1965, they said, we kind of have an idea that bacteria is the problem, but as we all know, you have to actually have some sort of data to substantiate this, right? So what did they do? They took two populations of mice. They had a notobiotic population and a conventional population. So everyone familiar with the term notobiotic?
Germ-free.
Germ-free, thank you. I like this guy. What we're going to do is we're going to do a co-lecture. Yes, so they were bred and raised in sterility, right? Then they went ahead and created pulpal exposures in these teeth, and then they observed for 28 days. And what did they find? In the notobiotic population, you saw dental bridge formation, and you saw vitality retained. Conventional population, guess what happened? You saw advanced decay, you saw abscess formation, you saw all the problems associated with endodontic infections. So from this study, we surmised that in the absence of bacteria, vitality will still be maintained. So the etiologic agent is bacteria and microbes. This was back in '65, so more or less all endodontic literature we kind of base upon this, okay? So microbes and endodontics, we understand we're dealing with polymicrobial endodontic infections. Again, we talked about different bacteria. Now, sometimes when we do root canals, we're going to do it in 2 visits as opposed to 1. Nowadays, with all the contemporary endodontics, vials, irrigation, things of this nature, we can have successful cases in 2 visits and 1, and there's no significant difference. However, you still cannot neglect that sometimes you still may need to apply an antimicrobial sort of medicament in between. Okay. And apical periodontitis fits acceptable criteria for classification as a biofilm-induced disease. Biofilm was an extremely hot topic in endodontics from, I guess, the past 6 years. It still is a hot topic, but now we're kind of moving away to cone beam technology and focusing on that. But everyone here is familiar with biofilms and why it's such a challenge to actually get in there and eradicate this bacteria. Because this is what you're up against. It's not just bacteria in a planktonic, free-floating state. No, we're dealing with bacteria that are sort of have a symbiotic relationship. They're feeding off one another, they're helping one another. They have mechanisms that are going to say, you know what, if this one dies, but this one actually aids it by helping it to block some sort of attack. Bottom line is, when we deal with a biofilm, we understand that you're going to need at least a 10-fold to 100-fold increase in whatever antibiotic you're using, whatever medicament or irrigant you're using to break this up. So when you understand what we're really dealing with, the infection, there's no reason why anyone should not use a rubber dam on any and all cases, right? There's no reason that you should try to maintain aseptic technique at all times. Because you want to be the best, you want to provide the best for your patients, so why not start off with the basics and do it right, right? Necrotic pulp tissue becomes a favorable environment for microbial proliferation. This schematic just is an illustration showing us that all up and down the canal we're going to have a lot of bacteria, but specifically down in this apical region, we can see there's sort of a separation down in here. Bacteria can penetrate these regions down here, get in the dental tubules, and populate these areas. So the goal is, how do we get down this canal, but how do we clean out this apical delta and be effective and have successful cases? Okay. We know that as we progress down, we're going to get more facultative strict anaerobes, some facultative, anaerobes. But we understand that we're dealing with bacteria that more or less live in the presence of little to no oxygen. So we want to get in there, reach, and change that redox potential, therefore giving us a better chance to kill that bacteria and have a successful case. So I don't want to hit you guys over the head too much with the microbiome, but I just want you really to understand it's so important to understand what you're really up against, because then you'll really understand what's the proper treatment to get the most successful cases. E. faecalis was very popular within the endodontic literature as well, specifically because it does have a biofilm. It has an affinity to have a biofilm formation. Sprat. No relation to you, right, Brad? No, but it forms a biofilm very easily, so it's good in the laboratory. You can run a lot of studies on it to see how it actually is going to respond in the tooth and what have you. But what's really special about this is that it is resistant to calcium hydroxide. I'm sure most of you guys use calcium hydroxide probably on at least a weekly basis, if not daily, correct? And the mechanism by which it works is it has a high alkalinity. So it's that very basic sort of nature that's going to disrupt the cell membrane and lead to lysis. A lot of people have a misconception that it's actually, it functions as an antibiotic, but actually it doesn't. It kills along some of the same mechanisms, but it's the high alkalinity, this pH, that really allows it to be effective. And what's interesting is when you are faced with an E. faecalis biofilm, you actually try to break up this biofilm with calcium hydroxide, you're not too successful because it has a proton pump, which is going to kind of counter that high alkalinity environment. Okay, so we oftentimes see that E. faecalis is very prevalent in refractory cases such as retreatment and things of this nature. Okay, so just giving you an idea that it's not just one bacteria we're dealing with, it's polymicrobial. It's a big challenge, so you have to have a lot of different things in place to go for a successful case. So, ideal irrigant properties. Let's go ahead and get into that. Can someone just give me maybe one property you would want in your irrigation, your irrigants? Okay, I like that. Yes, must be antimicrobial. That's, you can't have anything that's not. I mean, just throw anything out. We're just having a discussion.
Chelating agent.
Anything?
Chelating agent?
Chelating, yeah, that comes up a little later, but hey, we got to link up. Of course, it has to have tissue dissolution, okay? Non-toxic carcinogen, you don't want it to be carcinogenic. Lubrication, we understand that when you go into a canal with lubrication, you increase cutting efficiency by about 300 times. Yugo Henry. Not just knowing that she's a female researcher, but her name is Yugo-Henry, so that's just a lot of women are doing that, keeping their name and then taking their husband's last name after the hyphen. But she did that study and she showed that lubrication is valuable. There's a lot of values there. Easy application, you want something that's so hard to apply, you know, you're not having a headache trying to just use it. Inexpensive. Dentistry today has changed. I've been in practice in Manhattan for a year now, and it is a big challenge from a specialist standpoint. So you want to keep costs as minimal as possible, so that's definitely something you have. Substantivity. I know you already know what this is, right? But can someone else tell me what substantivity is? Essentially, when you place the medicament within the canal, you take it out, it's still going to have its effect, even after it's gone. So you need something that's going to have residual effects because you want to, again, kill off all bacteria. Inert, you don't want it to really react with the dentin and things of that nature. Penetrate dentin tubules, remove smear layer. This is what he was talking about when he said the chelator. Okay, it's going to chelate. Bind calcium and actually get in there and penetrate those tubules. So the best thing that we have nowadays is sodium hypochlorite. I put the 6% because if you ask any practicing endodontist, what percentage of hypochlorite do they use? And they say, oh, you know, I use 0.5%, or 2.5. You may want to consider sending those cases to me. No, but in all seriousness, we always advocate 6% hypochlorite because we understand that when you have this, you're going to have the best chance to kill off the most bacteria. Not too many things can survive in the presence of full-strength bleach. Okay? And in addition, it has tissue dissolution properties. There's a discrepancy. Sometimes they say it's 0.5%, 2%. Bottom line is when you have full strength hypochlorite, you don't have to worry about tissue dissolution because it's just going to happen. Now the concern with hypochlorite obviously is it's cytotoxic to tissues, right? And you don't want to be the dentist who had this happen to. Okay. This is a hypochlorite accident. It is real. It does occur. I've had some happen, not to this degree, but the patient may say, you know what, doc, my tooth is hurting for some reason. I thought I was numb. And you say, you know what, let's take a step back and really evaluate and see what's going on. So the thing is, you don't want to practice scared, but you should practice aware. So understand that this can happen, and that's why we don't like bleach, but if you practice well within the standard of care, it really shouldn't be a concern. But God forbid if it does, what you do, you just want to rinse out the tooth with copious amounts of water, okay? Reassure the patient, stay calm, be confident, you are the doctor. The patient is going to look to you for comfort, for reassurance. You don't want to lose your head, okay? Secondly, you're going to want some antibiotics, obviously some extreme pain medication, and worst come to worst, you may have to refer them to a hospital. They may need IV antibiotics, okay? They will rebound, they will be resilient, but they're going to have some days where they kind of look like Quasimodo, but at the end of the day, I'm just being honest. I mean, it's not a laughing matter, but you know, she's a lovely lady. This is just a disfigurement, but you should see her before and after. She's fine. Decreasing concentration reduces toxicity. Yes, so that's a good thing, but then you lose the antimicrobial effect and the tissue dissolution. Okay. Johnson, that's not me, it's actually another Johnson I know. But increasing the volume or warming it is something else you can use when you want to use your hypochlorite. Chlorhexidine. Any of you guys use chlorhexidine? Yeah. And why do you use it? Antimicrobial? Yeah, it's antibacterial. It is. It's a good antimicrobial irritant. Okay. Specifically, we want to target E. faecalis, which we know has resistance to calcium hydroxide. This is where we call on chlorhex. Good stuff. Make sure you always have 2%. Don't use the Paradex. It's not as effective. Get the 2%. It's good. Okay. Problem is, there's no tissue dissolution. So if you're trying to use it as a substitute for your hypochlorite, that's okay, but you're really not doing yourself any justice or due diligence because there is no tissue dissolution. So all that necrotic tissue, any vital tissue that's remaining, still has the potential to lead to infection. And it cannot remove smear layers, so we have to rely on things like this, EDTA. You guys are all familiar with EDTA? Right. 17% chelating agent. It's going to bind the calcium. It's going to go ahead and open up those dental tubules. You have to use this stuff after you use your hypochlorite, and then you can use it in between before you use chlorhexidine because there is a precipitate that forms if you use chlorhexidine right after hypochlorite. And then once you form that precipitate, you can't actually get it out. So make sure you always irrigate in between with this if you're going to use all three irrigants. And that's what you should do, but just make sure you do. So this is just a little schematic again, just kind of lists the characteristics and the different irrigants. And we can see there really is no ideal irrigant. So what we have to do is kind of combine them all to make our own ideal irrigant. And that's what you can do. As long as you know that, you'll be fine, but you just don't want to use one irrigation. You just don't want to use this one. You pretty much want to use all three if you want to try to achieve the best success in your cases. So we talked a lot about irrigation, and you guys might be asking yourself, well, what about instrumentation? Isn't that important? And really, that's another lecture. I really don't want to get into that right now. Instrumentation is extremely important. It's going to shape the canal. But this is another lovely study by a gentleman named Ove Peters. He does a lot of studies on instrumentation, CBCT scan images. And what he did was he took molars that were pretty much oval in shape, distal canals. This is the pre-op. And then you can see that he has different file systems. The headstrom is pro taper size 1, pro taper 2, and what have you. And then he went ahead and instrumented the canals, okay? So green is pre-op, this is post-op, and then what he did was superimpose green on red, and you can see that the green represents all the areas that have not been touched by the file. And he actually gives a range for the study, and he says it's around 45 to 65% canal wall that is not touched. It's a lot of canal that you're missing. So we have to rely on our irrigation to do the job for us. You're not doing anything by instrumenting the canal. So I just wanted to show you this so you can have a picture to really say, okay, by going up this file, I'm not doing too much. And actually for the protocol we're going to discuss a little bit later, you'll understand that you really want to use minimal instrumentation because there's a lot of valuable tissue or stem cells that you want to preserve in order to maximize the success of these cases. So developing a correct diagnosis. This is just something I wanted to put in here. Diagnosis is so important because diagnosis is going to dictate prognosis, correct? So first and foremost, you always want to listen to the patient. You'll be surprised at how much the patient will tell you. I used to just practice thinking I know so much. Yeah, Dr. Johnson just came out, top of my class, let me get this. But in actuality, I would misdiagnose cases all the time. So I wasn't listening. I was just perceiving that I was listening. So really listen to the patient. Study, study, study the pre-op x-ray. Take PAs and always take vitamins. I can't stress that enough. You really have to know what you're up against. Develop a baseline. This is very important for pedodontists. I know you guys see a lot of trauma, immature apex. Normal may be normal for little Jabari, but it's not normal for little Michelle. Okay, this is New York, so I'm trying to be culturally sensitive. We got little Jabari. But I mean, in all seriousness, you have to develop a baseline, see really what's normal for that child, what isn't. Because in cases of trauma, as you know, the tooth may not respond vitally, actually is, and vice versa. Okay. Reproduce the patient's chief complaint. That's the key. They say, "Doc, my tooth hurts when I do this." Make sure you do that and see if you still get the same result. Verify the problem is of odontogenic origin if you're going to start to do some sort of root canal treatment. Okay. So this is the part of the lecture where I probably would be asleep. So we're going to go ahead and call on somebody to wake everybody up. Can I please get a diagnosis, Dr. Pratt? What would you do? A patient presents to you, sensitivity to cold drinks. Doc, help me out. What's going on here? What do you think? And just so you all know, I came out of Case Western Reserve for my endo training. I studied at NYU, but he's going to be the newest addition to the Case Western endodontic class, so that's why it's called. This is how we train. We don't just sit around and talk. We call one another out, and you got to know your stuff. No worries, we'll help you out. We're all here as a team. We want to become better as clinicians. Doc, I have sensitivity to cold, so automatically you should be saying, this is necrotic, this is a sinus tract. You should just take 14 out of the question, right? How is a tooth that's necrotic going to have some sensitivity? So you start to look at maybe 15, maybe 13, 12, what have you. Bottom line, it was number 15. But the thing is, if you didn't actually listen to the patient, you take this x-ray, you jump in there, sure it needs the endo, but the guy's coming back the next day, Doc, I still got sensitivity, what's going on? And that has happened to me. So what I'm telling you guys is really listen to your patients, really study that x-ray, and it all pretty much just comes right to you. I think. So this is just kind of an outline of what clinical tests are going to give you the best chance to have a successful diagnosis. I'm not going to go through everything, but it's just kind of what we discussed already. Nothing is more deceptive than the obvious. I got this quote right, this is for sure. Like I was saying, in the endodontic literature recently, we updated our diagnosis chart, so pretty much you have to have a pulpal diagnosis and a variable diagnosis, right? There's always two. You can't just say, oh, tooth is sensitive to cold. No. Speak like a doctor. If you're talking to the patient, use layman terms. You know when you have a problem with your tooth, disinfection, let's get it clean. But amongst clinicians, we need to have a standardized code. So you always want to have a pulpal diagnosis and a periapical diagnosis. Okay? We're going to get into this a little bit later about thermal testing because it is so important to really know what's going on at that tissue level and see how it responds. But essentially you can see thermal test normal, reversible, pulpitis, irreversible, necrotic. Same thing for periapical, chronic apical, asymptomatic. Bottom line, I'm going to get into it a little bit further right now. Okay. So how many of you guys are using endo ice when you see cases in your clinics? Right. You use that, Dr. Frederick?
Yes.
That's good. As you should. Endo ice is a great tool to use. It's not going to be the end all be all, but it is very valuable. And the best way to do it is to actually take a little bit of cotton from like a pellet, ball it up, put it on your cotton pliers, spray the endo, just saturate it, and then apply it to the tooth, kind of around the cervical region. That's going to be the best. Don't use the little Q-tip. Sometimes it's good, sometimes it's not. The best way to get the best, elicit the best response is to go in there just like that. Okay. You're going to want to test all your adjacent teeth. Like I said, establish a baseline, see what's really going on at that level, and just make a comparison so that you know this tooth is normal and what's variable. So this is the new diagnosis that we use. You don't have to get acquainted with it right now, but just understand that if you start working with the endodontist and they are throwing these terms around, this is how we're taught, this is how we're trained, and it's good for everyone to know. Okay. The biggest change is though you have symptomatic irreversible ovitis. Doc, my tooth is killing me. Oh my goodness, please help me out. If that's the case, you already know it's irreversible. Don't try to be a hero and do, split a base down or anything like that. If it's already irreversible, it's nothing you can do. It's only going to progress and become worse. Asymptomatic irreversible ovitis, oftentimes the patient is not going to have symptoms associated, but you take an x-ray of bite and you say, oh, that decay is so advanced, they need some treatment. Okay, so that's asymptomatic. Pulp necrosis, we know this is more or less if you're doing retreatments, previously treated, and sometimes you guys may open up a tooth to do a pulpotomy and send it out. That's previously initiated treatment. Pulpal diagnosis. You ready for this? A fibers and C fibers. Oh, you guys are not see everything. Which develops first? C fibers? Say it like you mean. If you're going to speak, be confident. So if you're wrong, who cares? We're all doctors, we're all learning. C fibers, A fibers. C fibers develop first. Okay. What does endo ice test for? What does it stimulate? What type of fibers? A delta. So when you have a patient who comes in, young patient, immature apex, and you apply the endo ice, you may not always elicit a cold response. Oh, yeah, it's too necrotic. Take it out. No. You have to understand that those fibers haven't even developed yet. So you may not get that response. So you really have to do yourself due diligence and evaluate the case from a holistic approach, okay? A delta fibers are the last to develop. They tend to reside within the coronal, I guess 2/3, okay? And they're going to tend to be kind of in the peripheral, on the outside. So when a patient comes in, spontaneous pain, it hurts a little bit, sharp shooting pain, you know that's A delta fibers. C fibers tend to reside in a apical sort of region. They're more centrally located within the pulp itself. So when these are actually infected, you know that the decay is pretty advanced, because for a C fiber to be affected, the infection has had to travel pretty far down, and then it's also kind of going across the pulp tissue almost like that. Okay. They're going to be a little bit more slow conducting, and once you get that dull ache, that dull pain, that's when you know it's a C fiber. And you definitely still, both cases you need to do the endo, but you understand what you're up against, that the infection has progressed a little bit further when you have those things. Apical diagnosis, okay? Like we said, you always need a pulpal and you need a periapical. When you guys write up cases, do you guys use, what's some diagnosis terms that you use to, just convey the state of the tooth to your colleagues?
I try not to use non-healing with endodontists, and I still maintain that it's failed. So they always like to say that you have to use the new term, the non-healing.
Right.
But I still like the old one.
Old is good. There's nothing wrong with old, but this is just, it's a little more standardized, so we can all be on the same page. But again, you want to have an apical diagnosis. And this is very important for a lot of you pedodontists. You have to evaluate that whole area. If you're seeing teeth with immature apex, I think I asked somebody, what do you guys usually do when you have these cases? I said extract, Extraction is cool, but if it's necessary, you got to do it. But at the end of the day, as an endodontist, I come from a biased standpoint. My whole goal is to save the natural dentition. That's what I like to do. That's what we do as endodontists. Okay. So you really have to evaluate the tooth and see what can we really do. And then on top of that, can we even restore the tooth after this? So these are just some of the symptoms. Again, the biggest change is symptomatic versus asymptomatic apical periodontitis down in here. There's a famous researcher by the name of Strindberg. He developed a lot of criteria for endodontists to really determine if a tooth is healed or not healed. One of the big ones is the lamina dura, still intact. We won't really get into that. We want to see resolution of lesions, a lot of different things that we look for. But just try to familiarize yourself with this. I'd be more than happy to send anyone the link if you guys want to kind of get familiar with these terms. And apply them to your practice and see what happens. Okay. So this is the case I was just wanted to show you. It's just 5 canals, diagnosed with symptomatic irreversible pulpitis, lateral tissues. I just threw it in there because this is a nice place to take a break. You guys want to get some drinks, some more ribs, feel free. If you want me to run through the rest of it, the next part we're going to get into regeneration. I'll just go ahead and we'll start. So it's really up to you guys. Okay. Current treatment protocols. This is where I need a lot of audience participation. The last part was strictly all endo. This is where you guys come in. How many of you guys are seeing these type of cases, and what are you doing? Okay, here's an even better question. What's the basis for apexcation? What's the basis for apexagenesis? Excuse me? Which is which?
Apexagenesis is for vital tube, apexagenesis for necrotic.
Necrotic pulp versus vital pulp. And are you currently doing these procedures or no? When you see these, or you send it out to the endo, do you feel comfortable doing these type of procedures?
Personally, just done one anterior apexagenesis.
That's fine.
But, yeah, pretty much to the end.
Oh, it's into the endo, right? So that was how this whole, I guess, lecture developed. Dr. Hyacinth and I, we had a nice pool party hanging out, and we just started talking dentistry. And I said, I'm seeing too many kids. I don't mind. I have a playful nature. I know how to get along with kids. But sometimes it's just like, man, I work so hard. I have to be like, oh, how you doing, sweetheart? Here's a little, tooth pillow and this and that. And I don't mind. I like working with kids, but it's just that I'm used to seeing a lot of adults. We go ahead and do the treatment, and you don't have to stop and really just kind of, flip into that mindset. I said, you guys are so equipped to handle these patients. You guys train for this. You do it all the time, all day. So why not assume the responsibility to start doing more of these cases? Why do I see so many in my office? And she just pretty much said, well, what was it? I just don't feel comfortable, or you just figure that endodontist is our domain since it's below the cervix, or what's going on?
I mean, in private practice, we work on time, to do these procedures. For us also, it's going to take much longer. And
Right.
we've had a whole set of supplies, equipment, and it's not something that a lot of people feel comfortable doing, I think. So they send it out, but it's a problem. The endodontists also don't want to deal with anything else.
Exactly. So why is it that you guys don't feel comfortable managing these type of cases? Or do you feel that you figure that time is not your best ally?
I think it's a matter of doing a certain number that you feel comfortable in. This is like the first step is finding out how to do it properly.
Right.
And then when you get the case, you can go for it.
Okay. So, you have a tooth that's necrotic. The goal is you want to create an apical barrier, right? And what's the importance of having that apical barrier?
To promote the seals and the growth of the teeth.
That's a good answer. No. No, it's very good. But in actuality, you create the apical barrier so which you can have something hard upon which to operate against, right? So that's what we're trying to do. What are we trying to do in apexagenesis? Promote root development. Because we already understand, like I mentioned earlier, in the case of avulsion, there already is native tissue present. So to preserve that, these young children are very resilient. The pulp tissue is a lot of vitality. So you clean out the top portion, maybe put a little medication, and you hope that the apical will continue to develop as planned. Right. So calcium hydroxide, you guys use this all the time? Calcium hydroxide, maybe form of cresol. You guys still use it? No. Good. Because as the American Association of Endodontists, we're not big fans of form of cresol. Even though the evidence shows that there really isn't any sort of carcinogenic risk, it's still something we just kind of want to stay away from. So it's nice to hear that you guys are on the same page, because just when I was in residency in 2011, the pedodontists were still pulling it out the drawer, like, hey, look them up some form of crease, but we're trying to get away from that. Okay. So calcium hydroxide is great because it has been in the literature since 1920. Herman was the first to actually introduce calcium hydroxide to the dental literature. Okay, so that's a long time. It's been used in apexification. Was it either talked about dental trauma? The website? Andreessen. That's the go-to right there. Andreessen. All those Scandinavian researchers, top notch. Really good. Obviously it has antimicrobial properties and it's hygroscopic. You guys know what hygroscopic is? Oh, yeah. Okay, we finally got one. Hey, Dr. Allen, good to see you. Coming through here. Hygroscopic just means that it's going to pretty much dry out the canal. Okay. So in the presence of fluid, it's going to have a sort of drying effect. So hygroscopic, which is good. Sometimes you can't get hemostasis, maybe seeping. Just say, you know, let's put a little calcium hydroxide in and look at it, okay. MTA, I'm sure you guys are using this, right? No. Yes. Next. Mineral trioxide aggregate. It's just like glorified cement, really. But Tor Benajad is making a lot of money off of it, and good for him. He's a good guy. But you can see it's osteo and cemento inductive material. Okay, so it's going to promote healing because of these properties. An excellent biocompatibility. I can't stress that enough. That's why we really just celebrate this medicament, because the biocompatibility, if you go ahead and extrude it past the apex, it's not a problem. It's going to heal, right? Say you're packing it down, somebody calls you, look away, oh, what happened? Take an x-ray, you see it's extruded beyond the apex, but no need to worry because the biocompatibility is so excellent, it's not going to be any sort of inflammatory reaction. And it does have good antimicrobial sealing properties. Obviously, the big issue that's very difficult to place. Nowadays, there's new, I guess, products in the market. They have a paste that you can actually use. They have a putty. They're trying to become a little bit more friendly in terms of placement. But again, that's the biggest hang up with the MTA. So it is used in a lot of cases where you have apexification needs to be completed. These type of cases. But what we're here today to discuss is Hoshino's triple antibiotic paste. You brought that up. I'm glad you know that. So why don't you tell us a little bit about Hoshino's triple antibiotic paste?
It's a combination that has been, I guess, developed, and there's just several great case reports that show.
Exactly, case reports.
Mm-hmm.
We don't really have high level of evidence studies. And as an endodontist who believes in the literature and I like to practice evidence-based, you kind of have to take this with a grain of salt. But nonetheless, there is a lot of evidence in a case report or case study. Okay. So, Hoshino and Sato, these were the Japanese researchers I had mentioned earlier, Awaya. And this is where Bonches and Trope sort of got the idea and said, hey, let's go ahead and apply the concoction of ciprofloxacin, 200 milligrams, metronidazole, minocycline, and see what happens. Okay, you can actually make this. I did some research when I was in case, and I just had the local pharmacist just hook it up for me, no problems. A lot less expensive than if you get it professionally manufactured. And I actually had them add a radio opaquer, some barium sulfate, because the thing is, when we apply this, you want to see how far down you're going down the root, but it's very hard to do that when it's radiolucent. So I haven't had a radio opaquer. Propylene glycol is a good sort of carrier, and you mix to a creamy consistency. And then, of course, here's all the things that we celebrate again. Dental walls are going to be increased, strengthening the root against traction. So the thing is, when you guys are doing these cases of apexification, you may not fall with them because you're out in private practice now, right? You saw the child when you were in residency, and they're out. Thing is, we see these cases, they come back to us, and these teeth are fractured. Because what happens is when you complete an apexification procedure, wherever that growth is halted, it's going to stay there for the rest of the child's life. They're chewing on these teeth, they're subjected to just a lot of occlusal forces and stresses, and what happens? They fracture that much easier because they don't have any increased dental wall thickness, and they don't have any sort of apical development. Okay, so that's the real issue as to why we want to try something like this and look to regeneration. Okay. So, this is a slide right here. This was a pre-op. I think I got this from the AE website. Okay. You can see just all the infection in here. They went ahead and did the regenerative endodontic procedure. 7-month recall. You can see 24. Which is 2 different things. So, now we're going to get into a little bit of tissue engineering. I'm not going to bore you too much with this stuff. It's really not anything you really need to know, but it's kind of good to just be aware of what's really going on at the molecular level and why these cases working was so successful about it. Stem cells. We understand that stem cells have the potential to differentiate and just repopulate areas where they were missing. Correct? You guys familiar with stem cells? You have 2 types, embryonic and adult. In cases of regeneration, we're really relying on the embryonic pluripotential. So not only do they have the potential to differentiate, continuously divide, but just a high degree of proliferation. Okay? Just to populate that entire canal space, and now you can hopefully get a successful case. Now there's a lot of debate as to where these stem cells are developing from. Are they coming from the pulp dentin complex, apical papilla? Where exactly are they originating from, and why? The thing is, like I said, we're in the very infant stages of this research, so we can't really be for certain. But as it's best stated by George Wong, he's a researcher out of Boston, I believe, with some really good studies in terms of stem cell research. And he believes that it is the stem cells from the apical papilla which repopulate the canal, in these cases of regeneration, and actually fill up the canal with like a tissue-like substance. We don't really know what it is, but it's tissue-like. Okay. So these are the various stem cells that you can have. Human exfoliated deciduous teeth, you can have them from the PDL, dental follicle, but really the ones that we focus on, for all intents and purposes of this lecture, are the stem cells of the apical papilla. Now, in order to have a successful case, you have to have your stem cells, you have to have some sort of scaffolding. Just like when you're building anything, you have to have something that's going to kind of give you that structure, right? So you need a scaffold. What is the scaffold, and which ones can we use? There's a few natural ones, the blood clot, and that's the one we just want to focus on today, because this is what current regenerative endodontic procedures are going to use, a blood clot. So you're going to want to kind of stimulate the blood at the apical region, allow that to flow up to pretty much the cervix, cap it off with some MTA, cap it off with a little bit of composite, reevaluate the patient after some time, bring them back and see what happens. Okay. Growth factors, I'm not going to get too much into this, but you guys are familiar with TGF-beta, different growth factors, right? And pretty much they're going to send signals to induce proliferation and differentiation. So you kind of just have to have an understanding of everything that's involved with these cases to really get a successful case. So let's look at the clinical considerations. You must have a young patient, obviously. It has to be a necrotic pulp with an immature apex. And like I mentioned earlier, you don't want any sort of instrumentation, okay, as minimal as possible, because we want to preserve those stem cells that may be present in the dentin along the dental wall. Placement of an intracanal medicament. That's where the Oshino's triple antibiotic base comes in. Okay. As of late, some researchers have considered calcium hydroxide. Can anyone tell me why we would not want to use calcium hydroxide in a case of regeneration? Think about the properties. What does calcium hydroxide do?
Basic properties.
Excuse me?
The basic properties?
Any properties. I mean, the basic, that's definitely one of them. Well, it's going to create an environment of sterile necrosis, right? So, if we're trying to preserve these stem cells of the apical papilla, because the latest research tells us these are the ones that we need to, maintain, why place calcium hydroxide down? It's going to kill off those cells. Now you're not going to have a successful case. Creation of the blood clot, which is going to serve as the scaffold, and then, of course, effective coronal seal. I cannot stress the importance of a coronal seal. Okay, I can do the best endo in the world, and I just did one on my mom. But if she doesn't get back to Dr. Ontiveros in Denver and get that crown in a timely fashion, the whole case was in vain, right? Bray and Trope, the same Trope that I mentioned earlier, did a nice study, retrospective 5-year study. And they looked at cases where you had good endo, bad endo, good restoration, poor coronal restoration, right? And they found that when you have a a good endo and you have a good restoration, you have about a 91.4% chance of success. Now keep in mind, this was back in, what's that study? I want to say maybe 96, tough to say. So the success rate is a little bit higher now. It's going to probably be 96, 97. But the bottom line is when you had a good endodontic procedure, something that was done exactly textbook, and you had a poor coronal seal, guess what happened? That percentage, 91.4, now drops to what? 69. 69 said that. You're reading my notes, huh? No, but it drops well below 50%, so it's a problem. So whenever I see a case and I say, you know what, this restorability is questionable, I can do a root canal on anything, but if you can't restore it, why even try? And then secondly, if you're not going to take the proper steps to ensure that it's sealed out properly by using rubber dam, keep it dry and clean, why even do the case? You're doing a disservice to your patient. So here's the case that we were looking at. This is one of my cases from residency. Young patient presents, trauma to number 8. He was playing ball, something like that. So the diagnosis, necrotic pulp with symptomatic apical periodontitis, open apex. Okay? Not completely developed. We'll go ahead and instrument the canal very lightly, just to get down there. Really, you use this just to kind of get a gauge of how long the tooth is, because you want to know how far you're going to place your medicament, correct? So you're really not even touching the walls. As you can see, it's really just kind of loosely in there, but you just want to use this as a gauge, okay? Cannot stress the importance of irrigation. We already talked about all the irrigation. Sodium hypochlorite, we understand what it does, why we use chlorhexidine, EDTA. And you can see that EDTA, you want to leave anything longer than a minute, guess what happens? You're going to start to denature the dentin. It's going to disrupt it. It's not good, so you don't want to use it for too long. Okay? Go ahead and place your triple antibiotic paste down the canal slightly shy of the remaining apical tissue. Like I said, we had used barium sulfate, not for this case, but when we did the research, we added a radial painter to it. Temporary restoration cavity. Why 4 millimeters? Go ahead, Dr. Spencer.
Just to make sure that you have a good coronal seal. So
Yes, you want a very good coronal seal. But the real reason we use this is because Weber and Del Rio say that you need at least 3.5 millimeters of intramural material. Okay, like I said, evidence-based endodontics is what I'm trying to, convey to you guys. It's one thing to be a clinician and just do it because I know, but why not know why you're doing it? Have a little bit of research to back up what you're doing, because it will come up. It may not come up from a patient standpoint, but clinicians, we want to know what's going on. We want to know why. Why do you do this? So have a little something in your repertoire to just let them know this is why I do what I do.
So what would happen if it would be less than 3.5 millimeters?
According to that study, you're going to have some coronal leakage, and we already understand coronal leakage is a problem.
Was that just with CAVIT?
They used CAVIT. They looked at IRM.
What about using like glossanomor or composite amalgam? Something with a more definitive seal.
Right, and that's a good question. But the thing is, we have to go back in this tooth. So you don't want to put something like amalgam. You can, but it's that much harder to take out. And then you start to get amalgam particles down in there. It can be an issue. 26 days later, you're going to go ahead and irrigate with just sodium hypochlorite again. Stimulate the apical tissues. Pretty much you do this just by apical trephination. You guys ever done that? Anybody familiar with that process? Apical trephination. Get in there and just kind of put a file. The working length is maybe 19. Go 22. Okay, these kids, they have vital pulp tissue down, not pulp tissue, but vital tissue down in here. Stimulate that area, allow the blood clot to flow pretty much as far as you can. Go ahead, CAVIT, MTA, bring the guy back in 2 to 4 weeks, and restore with a bonded resin restoration. Okay, so that's pretty much the protocol. Like I mentioned earlier in the lecture, it varies. If you were to look at the literature now, this was back in 2010, 2011, we were doing this sort of stuff. Nowadays, other researchers are using different techniques. Bottom line is you pretty much have to have irrigation, okay, medicaments to disinfect and release the growth factors in the dentin. You have to sort of initiate some sort of bleeding from the apical region because you have to have these cells, these stem cells migrate into the pulp canal space. And you also have to have a blood clot and a hermetic seal. Okay, that 3.5 millimeters, that 4 millimeters. And then go ahead and reinforce that seal with something like a glass ion or what have you. Okay. So those are pretty much the three tenets that you must have, and we all clinicians pretty much agree that you have to have these three in order for it to work. Now there's a little bit of discrepancy of what medicament. Some people say, oh, you know, we're concerned about antibiotic resistance and this and that, so we don't want to use metronidazole. Or they say, you know, we're concerned about staining of the teeth, so let's stay away from the tetracycline family. We're not going to use metacycline. So there's different variances, but the bottom line is you have to at least disinfect the canal somehow. You have to establish bleeding, and you have to have a blood clot that flows into the canal, seal it up, and see what happens. This is very wordy. This is just a slide why we would use antibiotic and why not. Just to compare and compare and contrast. Like I said, here's one of them. Minocycline will cause tooth discoloration. I think this is pretty good. Very effective this week. Just to compare chart. That's how it is. So this right here is another study. I know you guys over here with a lot of literature, but when we're talking about something that is so young in terms of applications in the clinic, we don't have any long-term studies, so we have to base everything that we do on current literature. Okay, it hasn't been around since 1920, like calcium hydroxide. So just look at the properties. Okay, they're both antimicrobial, broad-spectrum antibiotic. Yes, we already understand this works based off of alkalinity. Radiopaque, yes, but you can add a radiopaque element to it if you like. Okay, anti-inflammatory, yes, they're both going to have anti-inflammatory properties. Increase root thickness. And I put this here because usually you're not going to have that. But like I said, recently, I think it was just maybe 6 months ago, some researchers have shown that if you use calcium hydroxide, according to how they did their study, they did get increased root thickness. Now it has to be reduplicated, it has to be duplicated and tried in different sort of environments. But according to their study, and the write-up looks official, they're making these claims. Increased root length and sterile necrosis, no, but we understand calcium hydroxide does that. Okay. So this is just a chart that kind of just puts what we just discussed into diagram form. And you can see they even looked at form of Cresol, and you see it really didn't have any sort of effect in root length, and it had really no effect on increasing the width. The only two that we really can use are antibiotic paste and calcium hydroxide. So what are you going to do for your follow-up? How do you evaluate these cases? First and foremost, is the tooth asymptomatic? And even more importantly, is it functional, right? If the tooth is loose, if there's infection, just take it out, okay? If the patient says, I'm still having pain, you tried it, it didn't work, it's okay, take it out. Radiographic evaluation, in 6 to 12 months, you should see a resolution of an apical lucency. You may see increased in the wall thickness. And that's not always asserted, but you may see this. Okay. 12 to 24 months, you should expect to see something like this. It's not always going to be a perfect sort of resolution of that apex. It's not always going to be something that's exactly like, a mature apex. But you should start to see something in here. And if you start to see lamina dura, a little PDL, I mean, you should really pat yourself on the back because that is hard to achieve. Okay. But if you do see that, you've done a great job. It's just a bit about histologic makeup. Like I said earlier, we're really not sure exactly what the tissues are that populate the canal. But some of our Japanese researchers have shown that it's a pulp-like tissue. What they did was they actually did these studies and they extracted the teeth. I don't know how they can do that, but again, this is Japan. I don't know what the standards are. Now, I'm not saying it as anything bad. I'm just saying they may have different sort of regulations. And of course, animal studies, which we don't like because it's low-level evidence, but there is some sort of significance to it. And they said it was actually cementum in bone-like tissues. But the bottom line is in a lot of these cases that have been sent to the database, we find that most of them do respond positive to cold testing. when they actually happen. Okay, and this was sort of like a case review that Law did, and he looked at all the cases, not all, but a huge sample size of the case that had been submitted. By and large, we are finding that teeth that were once necrotic, abscess formation, sinus tract drainage, you name it. If you go ahead and initiate this protocol, next thing you know, you're going to have vitality, increased dentinal wall thickness, increased apical development. So what is the future of these sort of procedures? I think it was in summer 2013, there was a nice article in the New York Times. That was the Wall Street Journal. And they actually were talking about regenerative procedures. And they interviewed an endodontist from, I want to say it's either Baylor, it was in Texas though. And she was discussing what the future is and what we can expect. We're all very young in here, and you will in your lifetime see this sort of procedure. Tooth decay that begins with pulpitis, inflammation of the dental pulp. Next thing you know, a researcher or yourself, the clinician, will fill the canal with pulp, stem cells, and molecules to stimulate growth. So no longer are we focusing on the stem cells of the apical papilla, but we've engineered in the lab the stem cells needed for this type of growth. Injecting that in from the coronal aspect, next thing you know, you get prompted growth, pulp cells, blood vessels, and nerves. Next thing you know, you have a regenerated tooth. There have actually already been some studies showing that this is possible, that it is reliable, that it is reproducible. But again, a lot of these things take time. You have to get the proper, government sort of patents and things of that nature to actually bring these sort of treatments to the public. But people are doing this stuff in the laboratory. Okay? And Case Western, the school that I came out, was actually on the forefront of a lot of this research. Really good stuff. Okay. So in your lifetime, you will see that we're going to grow teeth. And as an endodontist, that may be a problem for me. But hey, God is good. I'm versatile. We'll see what happens, what other career path I may choose. But this is exciting times. I think it's great stuff. I really appreciate you guys even coming just to hear me lecture. Not only this lecture, but just engage in conversation. And just, hopefully you learned something. I definitely learned from you guys as well. And keep in mind, dentistry is a profession where we can make money, so don't be shy. Try this stuff because we now have codes that you can actually submit. And so you're trying new things, but you can also get reimbursed. So it's a win-win. You're going to do a great service to the patient because you would have to do apexification procedures anyway, and if you do it correctly, it's going to take multiple visits. So why not take those same multiple visits and try a revascularization case? Document it. You're in residency. You have a lot of time on your hands in terms of working with patients. You're not like, well, maybe you are, I don't know. But hopefully you're not. So try these cases, and look, they have the codes right here. I don't know exactly the reimbursement, how much you get, but we are now acknowledging this as a viable treatment option. So go ahead and give it a try. Any questions or concerns, I'd be more than happy to serve as a resource. And I just really appreciate you guys coming out, listening, and hopefully we can get some more topics of discussion at the next event. Any questions, comments?
One comment. Commonly, I did something to my throat now. From a layman's point of view.
Yes, yes.
What I heard during your talk is
What am I doing myself?
what I heard during your talk is that dentistry is more preventative than curative, as I would put it, and that the dentist is more scientific in trying to save the patient's teeth than as was formerly, or your teeth is bad, then you extract it. Right? And it should be encouraging to these young folks who are getting involved into the profession to recognize the importance of doing constant research,
Yes.
so that they will be updated with what they're doing day by day.
You bring up a very salient point, and that's kind of the direction we're heading. And I think that's why we have legislation under Obamacare where now the provisions are expanded up until 26, and now these young patients are covered because we're trying to prevent tooth decay, we're trying to prevent tooth loss. And we understand that if we look at dental decay as a disease, which it actually is, that it's the most prevalent sort of disease that afflicts Americans compared to any other disease, right? Just think of all the kids. You guys remember Diamante Driver, young kid out of Maryland, I think, had an abscess tooth. His mom couldn't get him to a dentist, went to his brain, whole nine, died, right? That's a major problem. We should never have any child die because they can't get care. Not to be too philosophical, but I feel that dental, I mean healthcare in general, but specifically oral health, is a right and not a privilege, right? We should all be afforded that opportunity. But with these sort of treatment options, we can be the best clinicians because we can provide our patients with a whole host of treatment options and really, have some successful cases. So that's a great point there. That's my pops, by the way. Official, unofficial pops. Yes.
So I know we looked at mature teeth today, but
Yeah.
have you seen any cases with mature teeth, like in the case of external resorption, internal resorption, using the same procedure to promote? Because if you use the term regeneration, then that's kind of, speaking of the fact that it was already generated before, so to use it on the mature teeth, you know what I'm saying?
No, I do.
Yeah.
I think that's an extremely good question. In terms of external resorption, these sort of cases, usually these are going to be on mature teeth. We understand that once the tooth is mature, those stem cells are not going to be as viable. So we really don't have any cases, at least not to my knowledge, but you encouraged me to go look a little bit further and actually see if there are any cases that have been submitted. But it's really because we understand that in the young patient, because of the resiliency of the tissues at that apical region, that these cases can be successful. Okay.
Good question. Thank you. Very well organized talk, so I appreciate it. Appreciate your time.
Thanks so much. Yeah, I value you guys want to do a good job.
So quick question, like the polar opposites on pediatric dentistry and endodontics.
Yeah.
Is that I think we're both recognizing the pulp is a connective tissue, just like any other connective tissue in our body. But one of the things that I notice is different is that the American Academy of Endodontics will take like indirect pulp capping on an asymptomatic, hopefully normal tooth, and they do not advise that as recognized treatment option. Now on our side of the house, we have to see a lot of kids who don't have access to the endodontists that are going to see Medicaid. For which there's not many. So there's a huge need there. So if we preside this procedure, which evidence-based is telling us it's extremely reliable.
Yeah.
When you look over at, I think he's in Sweden, Lars Borndal and his research, he's had a randomized control. Yeah. So he had an RCT come out saying that gives you, far superior success to any root canal if you select the appropriate case. So based on your endodontic colleagues, is there any movement to recognize this? Because right now it's not an ADA reimbursable code. We don't get paid for this. And I just think as a culture, as a profession, we need to move to recognize the light. And most endodontists, especially that don't appreciate the literature or the actual evidence, are going to say, we're not going to make money doing that. So why are we going to waste our time? But for us, when we see kids, it's the kids that can't afford it and they can't, if I don't do that procedure, then I say, you just need an endo. You'll never be able to follow up. So I guess that's my question is, do you know of any movement among your colleagues, the young endodontists out there that we can kind of see eye to eye with?
I mean, that's a beautiful point. I can see that you have a good heart. You're really trying to treat the patient as opposed to just looking at it too. And I'm with you on that. I feel that if you can initiate any treatment that's going to be successful, meaning that the tooth is going to be retained, the patient's going to be asymptomatic, why not? Mm-hmm. The thing is to get it to be recognized collectively, by your association or what have you. I'm not too familiar with the pedodontic literature or how you guys all come together and support one another, but as endodontists, we lobby extremely hard for what we believe, and we have a very stringent board criteria to become board certified. So that kind of allows us to have a lot of autonomy and kind of dictating what treatments we accept and what treatments we don't. Okay. I don't know how it is for you guys, but I guarantee there are a lot of endodontists not just young as me or as old as me, but just in general, that are of the same opinion. And we just want to get out there and help and treat these kids, because you're right. If a child needs treatment and they're under Medicaid, there's not too many people are Medicaid. Not too many endodontists that I know that are actually going to get out there and do the work. But that's what was so important about having this discussion, because we wanted to say there's got to be some sort of nexus where we can come together. You guys are phenomenal at working with kids who have such, it's fearful for me. I hate seeing kids in my chair. And I love kids. I have like beautiful nephews and everything. I'm like, man, another kid? I get mad at the front desk like, I told you guys, why are you putting these in my schedule? It's like, seriously, I really cannot stand it, because it's such a challenge for me just to change my mindset. But you guys are trained, it's nice to have that. And so if we can sort of work together to actually have these successful cases, I don't know, but I think this is a good starting point. And I have a lot of like-minded colleagues like myself. So, maybe we can develop a little study club and, just have some further conversation, discussion, to see where we can go from there.
Go play some tennis.
What you said?
That's all
Okay. You want to say anything good?
I just have one more question.
Yeah, anything. We have time.
When you get the canal, bleeding in the canal, when you do the procedure, already you said that handling MTA is difficult. How do you then place the MTA in the presence of blood in the canal? And then
Well, the MTA, remember, you're allowing the blood to flow up to the cervical, the CEJ. So you have like direct vision, you just can place it right in there, pat it in there. It's not like you're pushing it all the way down the canal. So from that aspect, it's a lot more manageable. You can manipulate it that more effectively, because you're just staying within the coronal third, essentially. I mean, from my experience, I don't know if
so it's not really technically difficult.
I don't know, I can't speak for you.
I know MTA is like you make it stand-like, right?
Yeah, you want to mix it to like a consistency, nice kind of thick. You can mix it to different consistencies, but if you get what's the instrument called when you kind of scoop it up?
Or
Huh?
lavatory?
Something like that, yeah. And you just kind of just put it right in the coronal third. I think you'll be fine. Like when we usually say that's difficult to use, like when you're doing an apical. You guys do apicals at all? Retrofills, retro preps. That's a problem. You're in this small confined space trying to pack that into the apex. But I think if you give it a shot, I think you'll find surprisingly it's not that complicated.
Do you need to get pre-authorization for any of these codes? As far as you know?
That's a really good question, because I don't know. But it's not a bad idea. You don't want to start doing something you can't get reimbursed, but you're a sweetheart, so you do it just out of the generosity of your heart. No need to get paid.
It comes back to you eventually.
Got that Justin Bieber money. I only say that because she's from Canada. I like Justin Bieber, that's my boy. All right, so I guess if there's any other questions, we can get some ribs and some drinks.
I really want to thank everyone for coming out. I really want to thank Dr. Lori for pushing Marcus to have a discussion.
It's been a long time coming.
And make it happen. And thank Dr. Carrie Cunningham for being such a wonderful host over here. And if there are any questions, did you bring your card or?
I got a couple cards.
I have cards up front. I know how to get in touch with Dr. Johnson. And
You said you see kids, right?
See you later. That's how it's see them. No, but actually, Long Island, we do see a lot of kids, so I know it may not be easy to infer. In the city, I'll be honest, I really don't want to see kids. I mean, I will. It's not a problem. Right, that's why I'm having this conversation. That's exactly why I'm having the conversation.
But Dr. Johnson is very entrenched in organized dentistry. You head up Nassau County Dentist Committee?
Yeah, I do, and I'd like to extend an invitation to any and all of you. March 29th, we're having a blockbuster event. I'm the new dentist chair committee, committee chair. Committee chair. And it's going to be really nice because we're going to mix community service with some CE credits, and then everybody can enjoy the hockey game. I've never been to a hockey game out here, so the 29th of March. Okay. I can give you a flyer. You can disseminate the email. But yeah, everybody's welcome. Please come. We'd be more than happy to help you. I love organized industry because we have to have a voice. You know, we're the future. And if we're not up on it and making changes and leading these changes, who else is going to do it for us? So I encourage all you to get involved. You don't have to be involved as me, but you know, just at least show up to a meeting, see what's going on, and have a little say-so in the future, because the way healthcare is changing, the way the economy is, the way that the world is so competitive, we're so interrelated, the industry is changing, and you really have to be ready for those changes.
To that point, Empire Blue Cross Blue Shield is one of our sponsors, and they will be hosting a lecture about a lot of the changes. Later on in the year, probably around October, you were talking about some coding issues. There's a book back in the back of the room by Charles Blair. I don't know if you're familiar. He wrote Coding with Confidence. He has his MBA. The question is right there in that book. If you make sure you leave your email, we'll continue an open dialogue and make sure the conversation continues with regard to anything that we can offer you or anything else. There's some names on the boxes in the back. Drop your letters off. Take your box. Grab some beer. Not for you. Not for you. But there's plenty of drink. We'll turn on the music. Dr. Terry Cunningham, with regard to establishing and building his practice, is available to answer any questions, especially for a lot of the pediatric dentists out there.
Oh, thanks.
Yeah, Dr. Johnson. Look at
I know.
You want to start something?
Thanks, buddy. Thanks. Look at, hey, the questions are coming. I like this. It's good. I like this. Do you? Thanks, Mom. That's so cute. Yeah, pull it out. Right. That's what you get.
Oh, what's that? I'm not sure what it's doing.
Oh, these are gifts. Oh, this is yours, Hussein.
Oh, but there's a camera.
Oh my gosh.
Where are we dropping this?
Creepy.
What box we were dropping this in?
I think as many as you can hold, right? Isn't that how?
No. I mean, these,
I'm in the.
You're in the limelight.
yeah, maybe we could pause that.
Turn it around.
There we go.
Why don't you do this?